oxygen, bleeding. Now, they present exactly the same. Now, if these patients do happen to arrive at the hospital within 6 hours, then the neurologist or the internal medicine physician immediately wants to know, is it hemorrhagic or is it ischemic? Because the treatment is totally different. So, so your first thing that you can do, or that you should do, you do a CT of the head, non-carotid CT head, okay, for both of them, CT head. This will tell you whether if there's obviously a clear bleed because the blood shows up bright white on it, it's a hemorrhagic, right? Then it's a total contraindication to do alteplase or to dissolve it because they're already bleeding, so you don't want to cause more bleeding. However, if there is no clear sign of bleeding, you might be dealing with an ischemic attack. The ischemic change you see is unfortunately, you only see it on a radiograph later on. You don't see it immediately. But the fact that there's symptoms and there's no blood tells the doctor that it's likely ischemic. Okay. So that's the first important part. Now the issue is, however, small bleeds cannot be seen by a CT brain scan. The second thing is, if you want to do alteplase, it's a brilliant medication that can stop. It's given for heart attacks and it can reverse sort of most of the damage of heart attacks. It can also reverse strokes. It can also reverse critical ischemia. But because it's a heavy blood thinner, it has to be given on the right patients. And there's a whole list of contraindications. One of the biggest contraindications is a high INR. An INR above 1.7 is a contraindication, or at least a relative contraindication, because you can actually cause major bleeding and that might cause many more adverse effects than the actual stroke, believe it or not. So that's one of the big reasons why CT plus an INR level. So you don't have to do it on all patients, but if the patient is on warfarin, you definitely do. Obviously, if it's a normal patient that's never taken warfarin, there's no obvious signs of bleeding or anything, then you don't need to do INR for them. But definitely in patients that are on warfarin, you have to. And unfortunately, this type of patient population often has strokes and an INR because it might not be their first presentation. It might be a known patient with a vasculopathy, with a heart disease, they're already on INR, now they're coming in stroke. And honestly, it could be either the INR could be too high and that causes the bleed, or the INR could be too low and it causes ischemic stroke. Or even if it is a ischemic stroke but the INR is high, you still can't give the treatment. Okay, so that's quite an important topic. I just want to check if I'm still on the right track. Yeah, okay, blockage is ischemia, too much clotting, too little clotting. Okay, just one other note. So I spoke about alteplase that you can give. You can also do a thrombectomy, which is instead of giving the medication, you can actually go up with a stent basically into the artery and basically go and remove a clot in specialized center. I don't think we offer that here. On the cardiac side we do, but not on the neurology side. That is another option that one can do, and maybe for a patient that has a high INR where alteplase is contraindicated, you could do a thrombectomy and actually go in and remove the clot. So that, just to say, that is one of the possibilities. Okay, now so this is now for strokes. Just to quickly go back, okay, and that explains why INR is so important in the whole decision pathway. Because now, in this case, probably the doctor got a CT brain scan. I'm not exactly sure. In this case, it could have been one of two things. Either there was no bleed, but the patient wasn't warfarin, and they wanted to see if the INR is too high, whether you can go ahead with alteplase or not. Or maybe there was something small suspicious on the scan, but the radiologist couldn't say that there was a bleed clearly, and then you do something like the INR. If obviously there's very high INR, and you see that small spot on the scan, you're leaning more towards maybe it's an early bleed that's just not quite visible. So it plays a quite important role, and as I said, time is tissue, or in the case of neurology, time is brain. So the longer that is there, and if you can't reverse it, it becomes permanent. In the heart, and that's why I said these are quite similar, and why I just want to touch on myocardial infarction. Obviously we use troponin, and that's what people want their troponin as quickly as possible. Similar story, obviously different pathology. Well, the background pathology is the same. There's a blockage, and the heart doesn't get oxygen. The only thing that's better there is that the heart is actually painful when it doesn't get oxygen, so they present quicker. And then instead of a CT scan, you use an ECG, but still you use troponin instead of obviously the INR there. And there again, there it isn't about hemorrhagic versus ischemic, it's more to see that you get some cases where it's a so-called in-stemming, which is not a major heart attack, in which case you wouldn't necessarily give thrombolysis, and then you get some cases where it's a clear ST elevation myocardial infarction or a full thickness one, and then we would definitely give it. And the ECG guides you, but the troponin is quite important. In a normal ECG in a patient with leaking troponins, they might think it is actually a full heart attack, whereas in a patient that so basically when ECG isn't clear, you use troponin to guide you, to say this is a full heart attack because clearly you see a pattern of rising troponins, therefore I can go ahead and give the same medication alteplase. Whereas if it's obviously the unclear ECG and the troponin stays low, then you're going to handle it as angina. Just chest pain, you're not going to give alteplase because it itself has its risks. So you don't just give it if you're not quite sure that it will make a difference.
Just
Yes, please.
here. And then where your ECG and your troponin I is not
Discordant.
conclusive. Yeah. No, but it does not indicate that it is a heart attack. Just important, will they repeat it after
The troponin.
the troponin?
Yes, okay, good question. And
As a borderline.
yes, absolutely. It's a good question. So, the definition of acute myocardial infarction, you need two subsequent troponins to look at the rise or fall pattern. So remember, a patient with, let's say, chronic kidney disease can have an elevated troponin, usually mildly elevated. But if you take that troponin again after 2 or 3 hours, some protocols say 2 hours, some say 3 hours, and it's more or less the same, they talk within 20%. So if there's a less than 20% change, it's not regarded as acute myocardial infarction. Yes, there's troponin, there might be troponin leakage from the heart, it might be due to the fact that the kidneys aren't excreting it, it might be due to the fact that there's underlying heart damage, but it's not acute, it's not a heart attack per se. So that's why the troponin is good. If it's a negative troponin, often we can rule out. If it's a positive troponin, you cannot get ruled in. You need to do a follow-up to look at either a rising or a falling pattern. And why do you say rising or falling? Because if this is the concentration on this axis and the time on this axis, troponin leaks like this. Okay? So it depends on when the patient presented. If you do your first troponin level here, let's say this is 50, right? And then you do your next one here and it's 80. There's a clear rising pattern. Okay, but let's say you did your first, the patient presented late, you did your first one here, it was 80. And then a few hours later you do it, and then it's, let's say, 40. It went down, so you might think, oh wow, great patient is fine. No, there's still leakage, and the fact that it has changed of more than 20% tells it's still acute. So that's why the definition clearly makes it a rise or fall of more than 20% in a specified time period, either 2 hours or 3 hours, equals acute myocardial infarction. And in that case, in most cases, they will then give alteplase to remove any clots that might still be there.
Means why that second troponin is just as urgent as the first one.
Absolutely, yeah. And yeah, absolutely. And hence why we talk about high sensitivity troponin. If you've ever wondered the name high sensitivity, it means by definition the CV is less than 10%, and you need a CV less than at least at the 99% of the normal population, and the CV must be that low to be able to distinguish in that 20% up or down. You need a low CV to be able to distinguish between those cases. Because imagine your CV was now 30%, right? And you do two subsequent ones, and suddenly there is a 20% change in the two. You can't say that person has myocardial infarction. It's just that the accuracy of your assay fluctuates too much. So that's why the assays must be within 10%, so that you're able, when you see a 20% change, you can say with confidence, okay, maybe 10% of that was due to our assay because we have a limit up to 10%, but the other 10% was not due to our assay. It's an actual change in the biological status of the patient, therefore the patient has an acute myocardial infarction. So, okay, myocardial infarction, strokes, role of INR, role of troponin. And just to re-emphasize the two main topics, our test and imaging for that matter and ECG play a critical role in various decision pathways where literally the presentation is there and it could be this or it could be this. If you go down this alley, it means that management is this. If you go down that alley, the management is that. And they depend on us to guide them into this direction or that direction. So that's the first thing. And the second thing is time is tissue, whether that tissue is heart, whether that tissue is muscle, whether that tissue is brain, time is tissue. So the quicker we get them that answer, the quicker they can make the decision and not miss the boat and still save functionality when it comes to the brain and still save the heart tissue when it comes to the heart and still save muscle tissue when it comes to critical anesthesia. Okay, that's it. Short and sweet. Please ask questions if there's anything unclear.
I think